everyone. I know it's towards the end of the day, but just have a couple more talks and then get some of that sunshine some more. So I'm excited to talk to you all about new IBD medications. Here are some of my disclosures. So first, we're just going to talk about very briefly the progression of IBD medications and kind of understanding the need for new medications. And then we'll get into the overview of new medication options for ulcerative colitis and Crohn's disease. Just by a show of hands, how many actually see IBD patients frequently and are prescribing biologics and small molecules and all the therapies? Okay, very good. And then very briefly, we'll talk about the future of IBD medications. So I just want to first do a quick walk down memory lane. You know, I always think it's interesting to see where we came from and see where we are now. So before 1998, we only had steroids, 5-ASAs, 6-MP, and methotrexate. And as we all know now, steroids are not a maintenance therapy for IBD. And the other therapies are more so for that mild and moderate inflammation. So you can kind of imagine how challenging and difficult it was for patients that were refractory or had severe disease. Thankfully, with time, we had the introduction of biologics, and now we actually even have targeted small molecule therapies. So I think it's important to kind of think about why do we have these newer therapies, and why are we always having to push for more and more new therapies? And it kind of ties into what are our goals for our patients and how are these new therapies filling in those gaps. So one is we actually don't have a medical cure for inflammatory bowel disease. So all of our therapies are kind of geared towards blocking an immune pathway. And due to that, a lot of our patients have primary or secondary non-response to medications. And a lot of patients are refractory as well. And also patients have aversions, and clinicians also have some aversions to therapies and nervous to start certain therapies. And a lot of that circles around safety concerns. So what has these newer therapies brought, and what will newer therapies bring us? One is new mechanisms of action. So patients that are refractory and have used a lot of different therapies, new therapies bring a different immune pathway that's being blocked, and potentially getting them into remission. Also, new delivery systems. So we had infusions, now we have subcutaneous injections, and now our small molecule therapies are oral, so giving our patients different options as well. And also, a lot of our newer therapies actually have better safety. So our safety data is actually very good in some of our newer therapies, which really helps with those patient-clinician aversions with our safety concerns. And our newer therapies also have low immunogenicity. So a lot of our earlier therapies like adalimumab and infliximab, which are our anti-TNF therapies, there's that risk of antibody formations with them. So a lot of our newer therapies have little to no risk of those antibody development, which makes it easier for them, especially if we've all experienced patients getting issues with their insurance or having hiatus off therapies. So this also makes it really easy when these newer therapies don't have that risk of antibody formation when we're trying to start them back on the therapy. And of course, with our new therapies, we've actually had improved clinical trials. So initially, back in the day, all the clinical trials, the endpoints just said clinical remission. Are the patients feeling better on this medicine? But now our clinical trials actually show endoscopic response and histologic response. So that's actually gearing towards what our goals are for our patients. Is we want them to feel well, of course, but we also want to make sure that their colons are healed. And so our clinical trials are now including that, and that really helps us know, hey, are these newer therapies working, and where do we actually sequence these therapies? And the most important, our newer therapies help us bring better remission rates. So these newer therapies are another option for our patients to get into remission, and also the clinical trials are also showing that they have better remission rates at times as well. So I just want to just give you a timeline of different IBD medications. As you can see, in 1998 is when the first biologic came about. It was infliximab for Crohn's disease. And you can see over time all the different biologic therapies. And then obviously more recently, you can see the small molecule therapies in that cluster over the last couple of years, where we've had a lot of newer therapies that have come out. So I'm just going to get started into the actual newer therapies for ulcerative colitis and Crohn's disease. Of course, each of these therapies could be a talk on its own for an hour. So this is just very high yield, just as clinically relevant as possible. If you're actually prescribing these medications, it's really important to make sure you're doing a deeper dive and really being able to get all the information to counsel your patients. But I just wanted to give you a little highlight about our newer therapies. So I'll first start about the biologic therapies, and then we'll get into the small molecules. So first we'll talk about risankizumab. It's approved for moderate to severe Crohn's disease and now ulcerative colitis. It is an IL-23 specific inhibitor. And the way that it is given is it's an IV infusion for induction and then subcutaneous for the maintenance phase. And it is a first-line therapy, meaning that you don't have to have failed another therapy to be able to prescribe this for your patients. So it can be the first biologic that the patients can be on. And because of the other indications that risankizumab has for rheumatology and dermatology, this is a good medication to think about if our patients have other extraintestinal manifestations with their skin and their joints. And overall, compared to placebo, actually had a very good safety data. So one of those medications, if a patient is a little bit nervous about safety or if they have a lot of comorbidities, one of the therapies that's actually quite safe. There is actually no pregnancy and breastfeeding data for risankizumab. However, we do have safety data for ustekinumab, which is an IL-12 and IL-23 medication. So there is a little bit of an overlap with the mechanism of action. So not saying that you can always 100% extrapolate that, but just something to keep in mind when we're counseling our patients, and if this is the last therapy that they can be on, having that shared decision-making conversation with those patients. And here's the dosing for risankizumab. So the induction is an infusion. It's 3 doses every 4 weeks. And then the actual maintenance is every 8 weeks, a subcutaneous on-body injector. The difference between Crohn's disease and ulcerative colitis dosing is Crohn's disease has, for the induction infusions, is 600 milligrams, and the induction infusions are 1,200 milligrams for ulcerative colitis. So I wanted to bring in a little bit of clinical trial data just to give you a taste. Obviously, these are just a couple of endpoints for each of these therapies. And something important to note is if I give you information about the remission rates for this medication, cannot really compare that to another therapy. All of the study designs for the clinical trials are different, so we can't really compare 2 different therapies just by looking at this data, unless it's an actual head-to-head trial. And I will be talking about a couple of those. But for risankizumab for Crohn's disease, as you can see here in blue, that's risankizumab. The gray is placebo. When it comes to clinical remission and also endoscopic response, higher rates in our risankizumab group compared to placebo. One thing I will note is you will see that it says mixed population and biologic failure. So clinical trials nowadays are actually including patients that have failed advanced therapies, meaning that they failed a biologic, they failed a small molecule therapy, and they're also including a subset of patients that are advanced therapy naive, meaning that they have never been on a biologic or small molecule therapy. Patients that have failed an advanced therapy, such as failing a biologic or failing small molecules, they actually have lower remission and response rates compared to those patients that are advanced therapy naive, because the first therapy that a patient's on, usually they end up responding the best to that one. So you can actually see that in our clinical trial data, and it's with most clinical trials for IBD. So you can see in the Motivate group that there is a biologic failure population. They had lower endoscopic response percentages and lower clinical remission percentages compared to the advanced group, which was the mixed population that had naive and biologic failure. And going to the risankizumab for ulcerative colitis, this is clinical remission at week 52. Once again, they kind of separate the overall population that have naive and failure patients, and then just showing the advanced therapy naive. Once again, you can see that advanced therapy naive patients have higher rates of remission compared to our overall population. So there was a head-to-head trial comparing risankizumab and ustekinumab. So risankizumab is that IL-23 inhibitor, and ustekinumab is the IL-12 and 23 inhibitor. And this study showed that risankizumab was non-inferior to ustekinumab for clinical remission, and that was their primary endpoint. There was other secondary endpoints such as endoscopic remission, and risankizumab was shown to be superior to ustekinumab for the other secondary endpoints, of that including endoscopic remission. The study also showed that risankizumab works if these patients had been on ustekinumab before. So if there's a patient that's been on ustekinumab and you're wondering, hey, should I really try this medication because it's a very similar mechanism of action, it's actually been shown that it can be effective. And it also showed that risankizumab is more effective than ustekinumab in patients that have failed an anti-TNF. So we'll move on to our next one is mirikizumab. It's approved for moderate to severe ulcerative colitis. It is also an IL-23 specific inhibitor, and same type of mode of delivery, IV infusions for the inductions and then subcutaneous for the maintenance. It is also a first-line therapy, so once again, it can be the first biologic that these patients can get started on. And because of that mechanism of action of that IL-23 inhibitor, has very good safety data. And once again, there's no pregnancy or breastfeeding data. There's just not a lot of data for these therapies right now, and so making sure that we're counseling our patients. And as far as for dosing, for the infusion, it's an induction IV, 3 infusions every 4 weeks. And then as far as for the maintenance phase, it's every 4 weeks, a subcutaneous injection. And once again, just wanted to pull in just a little bit of clinical trial data. At week 52, clinical remission, you can see that the mirikizumab group, 51% of patients were in clinical remission compared to just 27% of patients in the placebo group. In DDW, they did show that there was a new paper about mirikizumab versus ustekinumab. So very similar to our, wasn't set up in the same way, but kind of a head-to-head like our other head-to-head. It was a VIVID-1 phase 3 trial. And then this one showed that mirikizumab was not inferior to ustekinumab for clinical remission. And then as far as for the secondary endpoints, such as that endoscopic response, it was not clinically significant. So the numbers had greater rates in the mirikizumab group, but since it wasn't clinically significant, we actually cannot say that mirikizumab was superior to ustekinumab. So now we're going to move on to our small molecule therapies. So this is upadacitinib, approved for moderate to severe Crohn's disease and ulcerative colitis. It's a JAK1 specific inhibitor. It's oral, it's once a day, and it's a pill. And patients have to have failed an anti-TNF therapy to be able to be started on this medication. Because, once again, there's other indications for dermatology and rheumatology. A great medication to think about when we have a patient that has those extraintestinal manifestations with their skin and their joints, can actually get coverage for that as well, potentially. And it has a very fast onset. So these small molecules therapies in general have faster onset, but in particular, JAK inhibitors are known to have a very good fast onset. So the clinical trial showed that within 2 weeks, some patients would actually have some sort of symptomatic response. Because of this fast onset, there's been some off-label use in using this medication in patients that are actually in the hospital for acute severe ulcerative colitis. So you can imagine how quickly it can potentially work if they're using it for patients that are very sick in the hospital. So as far as for some safety data, there is an increased risk of herpes zoster for JAK inhibitors in general, but upadacitinib. And so for these patients, I always recommend them to get the Shingrix vaccine. So it's the non-live shingles vaccine. It's very effective. So essentially, if they end up getting the vaccine or they've had the vaccine before, that risk of herpes zoster is essentially very, very low. I don't expect my patients to actually have completed this series before being able to start upadacitinib. I just say, hey, let's get the vaccination series started. So a lot of times if they're in clinic and I'm already counseling them on the therapy and we're getting those initiation labs, I just say, hey, do you want to get your first Shingrix vaccine? You get the first shot and just get that done, and then you can get the second shot when we have our next follow-up visit. This is also not safe during pregnancy or breastfeeding, more so just because there's just not a lot of robust data about upadacitinib. And here's the dosing for Crohn's disease and ulcerative colitis. For induction, it's 45 milligrams daily for 12 weeks for Crohn's disease. For ulcerative colitis, it's 45 milligrams for 8 weeks. And then for the maintenance dosing, it's the same. It's either 15 milligrams or 30 milligrams daily, once a day for the maintenance. The label actually says to use the 30 milligram dosing if the patients have severe disease. Most of my patients end up having severe disease and they are very symptomatic, so I end up using the 30 milligram dosing almost in all of my patients. And I'll show you some trial data. You can also see that they actually have better response and remission rates in the 30 milligram dosing as well. However, there are some patients that, I'm sure all of you have experienced, they want to be on the least amount of medicine or try to get off of medicine. So I just let them know, hey, we'll do the 30 milligram dosing. If you end up being in endoscopic remission or deep remission in your colonoscopy in the future, we can have that conversation about decreasing to that 15 milligrams and monitoring you closely. But initially, if they have severe disease, they should be on that 30 milligram dosing. So here's a little bit of clinical trial data. So for Crohn's disease, clinical remission at week 52, you can see upadacitinib in the yellow, and then the gray is placebo. Of course, higher percentages in our therapy group compared to placebo. And you can see here, as I was noting before, that 30 milligram dosing group having the higher rates of clinical remission and endoscopic response compared to the placebo. And as far as for ulcerative colitis, very same theme, clinical remission and endoscopic response at 52 weeks. Of course, higher in our therapy group compared to placebo, but really that 30 milligram dosing group has higher rates compared to the 15. The next small molecule we'll talk about is ozanimod. It's approved for moderate to severe ulcerative colitis. And it is a S1P inhibitor, specifically R1 and R5. It is also an oral once-a-day pill, and it is actually a first-line therapy, unlike upadacitinib. And it is actually a medication that can be used, like I said, for moderate or severe ulcerative colitis. However, it has some specific data showing that it's actually very effective in those patients that have moderate inflammation. So actually some of our newer guidelines that are coming out and how I actually use ozanimod is those patients that have failed a 5-ASA therapy, they're in that moderate inflammation group, and it's a great step up from that 5-ASA or mesalamines to actually escalate therapy, but it's still an oral medication. So this is kind of that subset of patients where I actually really think about using this medication. There is some safety data in regards to cardiac, varicella zoster, and macular edema. I will be talking a little bit more about the safety data here in a second, but I just wanted to put this up here on the slide. It is not safe during pregnancy and breastfeeding, more so just because we just don't have a lot of robust data in that area. As far as for the dosing, it is a titration, so from day 1 through 4 and then 5 to 7, there is a slow titration upwards. But after the first week, it's a once a day, 0.92 milligrams daily. And just pulling in a little bit of that clinical remission data at week 52, as I was talking about that moderate inflammation group. So you can see here that moderate inflammation group that have never been on a biologic before. So really some of those patients that have been on mesalamine, they're continuing to have flares and your fecal calprotectin is still elevated, and you want to step up, but they don't want to be on an infusion or subcutaneous. Great medication to say, hey, this is an oral therapy, and it's actually a little bit more effective in your patient population as well. So etrasimod is our next small molecule therapy. It is approved for moderate to severe ulcerative colitis as well, and it is also an S1P inhibitor, specifically R1, 4, and 5. It is an oral once-a-day pill as well, and just like ozanimod, it is a first-line therapy. So once again, don't have to have failed another therapy to be able to get started on this. And also the same subset of patients I think about this medication for, not saying you can't use it for severe inflammation patients, but really for those patients that have moderate inflammation, who have failed a mesalamine, this is a therapy to think about. They actually had some specific data about isolated proctitis. It actually showed that there actually was very effective for patients that had isolated proctitis. So another subset of patients to think about using this medication. It has very similar safety concerns because of being an S1P in regards to cardiac, varicella zoster, and macular edema. Also not safe for pregnancy and breastfeeding. I think you're seeing a theme here that we don't have a lot of robust data in this area. So, just something to think about when we're starting these medications for patients. Really, really important to ask them if they're thinking about conceiving, or might be in the future, or thinking about breastfeeding if they've just had a baby, things like that. So for dosing, there's no titration for this. It's just 2 milligrams oral once a day, and like I said, no titration involved with etrasimod. Pulling in some clinical remission data at week 52, actually 12 and 52, and you can see the bottom square showing those biologic and JAK inhibitor naive. So really those patients that I end up using this medication for a lot is going to be in this group of patients, and you can see that they have a slightly better response rate than the total population. So getting into the safety. So S1Ps and safety, a lot of people get a little bit nervous, but when you actually break it down, it's really not as bad as it seems. So the label actually says that there is a contraindication to using ozanimod and etrasimod in patients that have AV nodal blocks, sick sinus, TIA, a cardiac event within the last 6 months, and severe sleep apnea. And the reason being is that when patients are initially started on this medications, some patients have a transient decrease in their heart rate. So when I say transient, it happens usually sometime within that first week of starting the therapy. And when I say it's minimal, it does not actually, rarely ever causes bradycardia. So for example, for etrasimod clinical trial, it said the mean beats per minute that was decreased was 0.7 beats per minute. So you can see that's a very minimal decrease in their heart rate, and it's transient. So after that first week, their heart rate goes back to their baseline. And when you're looked at the clinical trials, very minimal discontinuation rates, meaning that very rarely do patients actually say, I need to get off this medicine because of the symptoms or the side effects from this, and very rarely were there any episodes of bradycardia. However, before we start this medication, we want everyone to get an EKG. So this checklist is all the things that need to be done before getting started on these therapies. And number one is an EKG. Want to make sure they don't have any underlying arrhythmia that they're not aware of. And of course, just when we start any medications in general, want to go through that medication list, make sure that we know that there is no interaction with any other cardiac medications that they may be on. And also really deep dive into their history. A lot of times I ask my patients in clinic, I'm like, hey, do you have any issues with your heart? They're like, no, I'm fine. And then you look and they had a CABG like a year ago. So, just making sure that, you're actually looking at the chart yourself and really asking them specific questions to your patients about this. And then the next is patients who are on S1Ps, they have potentially an increased risk of varicella zoster. So they actually say on the label to, one of the things is ask them for documentation of their chickenpox, and as we all know, no one has documentation of their chickenpox other than anecdotal, hey, I have a scar on my face from my chickenpox. So most of the time I end up having to say, let's just get the blood test for varicella zoster. It's that IgG blood test. If it does show immunity, they're good. If they're not, then you should get vaccinated. And then all patients should actually get an ophthalmology exam because there is some patients in the clinical trials that actually got macular edema. The patients that end up getting macular edema when they were off the therapy, it went away, but we want everyone to get an eye exam before actually starting the therapies. And as far as for the skin exam, this has changed. It's actually for both ozanimod and etrasimod. They want everyone to get a skin exam before or soon after starting the therapy. And personally, any IBD patients that are on biologics or small molecule therapies should be getting skin exams anyway, so this is just good health maintenance, but specifically they should be getting it before or very soon after starting this therapy. So I just want, this is actually a chart from Dr. David Rubin from Crohn's and Colitis Congress earlier this year. It's just comparing ozanimod and etrasimod. I'm not going to go through all of it, but just some things to keep in mind is that ozanimod does have some interactions with CYP450 medications in that pathway, so making sure, once again, we're going through that med list. I know, as we mentioned before, those med lists can be very long, but it's really important that we're going through them before we're starting this medication. In addition, there's a little bit of difference with the half-life. Ozanimod has a little bit longer of a half-life than etrasimod. Most of the time, that doesn't make a huge difference, but something to keep in mind about patients that or if they say that they might be getting pregnant in the future, or if they're very prone to side effects, then knowing that ozanimod might take a little bit longer to wash out of the system than etrasimod. So I'm just going to touch upon this very briefly. Once again, this can be a whole talk on its own, but anyone that's actually prescribing biologics knows that we're always getting these messages and faxes from the insurance companies saying, hey, this isn't approved anymore, we want them to be on this biosimilar. So biosimilars have been compared to the FDA-approved biologic. They're highly similar in structure and function, and they've actually, of course, been tested, and they don't have any clinically meaningful difference between the biosimilar and the biologic. So just very briefly to touch upon, from the data that we have, we know that it's safe to go from a biologic to a biosimilar, and going to a biosimilar back to a biologic. Of course, it's, a lot of it has to do with just insurance and costs as far as which of these the patients end up getting on. I know it can be frustrating for the clinician to having to keep changing them sometimes, and of course for the patient as well. Anecdotally, there's been a few patients that I've had that actually have had a flare sometimes from switching and objectively had an elevation in their fecal calprotectin, but those are very rare cases. In general, it's very safe to actually be switching between a biosimilar and biologic. And just so for everyone to kind of know, infliximab and vedolizumab, they are medications that are completely IV infusions. They are now having subcutaneous injection options for these therapies. So on the horizon, so there's always new medications that we're thinking about that are coming out for inflammatory bowel disease. There's another IL-23 inhibitor that's in phase 3. The early data from DDW actually showed that, it might have very good data so far, so this might be something on the horizon very soon. And we're actually seeing that there might be a new mechanism of action in the future, so which would be great. And then we also have a couple of S1P modulators that potentially are out on the horizon as well. So just wanted to do a very brief summary. And, obviously we've had mesalamine prednisone therapies, but now we have biologics and small molecules. These newer therapies have really helped us bring better remission rates, new delivery systems for our patients, better safety, more options for our patients. So risankizumab and mirikizumab, they're the IL-23 inhibitors. They have good safety, and they're shown to be non-inferior to ustekinumab. Upadacitinib is that JAK inhibitor. It's for ulcerative colitis, fast-acting. It's an oral therapy for anti-TNF failure patients. Ozanimod and etrasimod are the S1P modulators. It's a first-line oral therapies, somewhat to think about for those patients that have moderate disease or proctitis. They do have specific pretreatment requirements for their safety, so making sure that you're going through that checklist. And of course, like we just said, there are biosimilars and other injection options available for some of our infusions now. But does anyone have any questions?